Hello, this is my first video that I'm making, and so I assume that there will probably be a little bit of a learning curve here. But, anyways, welcome to Learn with Dr. C. And today, I wanted to just go over, let's go over. Let's go over some antipsychotics. Most antipsychotics that we use in the hospital are second generation. They're also called atypical, but I never liked that word because atypical. Antipsychotics are kind of typical. Not, and I don't want to confuse you too much, but atypical antipsychotics or second generation antipsychotics are pretty much the mainstay of what gets used. You see some Haldol and sometimes Prolixin and Thorazine getting used in the hospital, but it's not actually that often. Most of the time, it's Zyprexa, Risperdal, and sometimes Abilify. Those are really the mainstays here. So let's talk about, sort of when you would choose one over the other. That's something that a lot of people that are new to the hospital, want to know. So we got Zyprexa. Risperdal. This. Well, there's a learning curve aspect of things. What was that? Forgot. I found it. Okay. So, where's Zyprexa, Risperdal, Abilify. Okay. And if you wanted to be, a bit of a gunner, you could call Zyprexa by its chemical class, dibenzapine, Risperidol by its class, benzoxazole. And Abilify by its class, quinolone. So, really, a lot of choosing the antipsychotic that's right for you depends on how effective you need it to be, how quickly you need it to be effective, and the side effect profile that'll be more favorable to your specific patient. So when we're talking about a side effect, so Zyprexa, so they can all do pretty much all the side effects. And I'm sure that in your training so far, you're aware of the general, side effects of antipsychotics. But with dibenzapines, we're talking about metabolic being front and center. So weight gain and diabetes and whatnot. Benzoxazole, it can still do all that stuff, but much more EPS, Parkinsonism. And Abilify, we start thinking about akathisia. And when we're talking about effectiveness, and this isn't me, quoting a study here. This is, my work in psychiatric hospitals over the last decade. And, just the easiest way for me to explain to you how to treat people the best is that Zyprexa is the most effective and the fastest. Risperdal, close second. Abilify, not quite as fast, and for psychosis, not quite as effective. And with a caveat that really is only true for pills. Effectively. LAI formulations of so the LAIs of Abilify, like the Abilify Maintena and Abilify or known as Aristada, they both do treat psychosis pretty much equally to the Risperdal and Invega type long-acting injectables. They do have strong head-to-head studies that show this. They meet all the right outcomes. So there's something sort of hard to explain there, where the LAIs are pretty much equal, but the pills we see just a lot more akathisia, slower improvements, and sometimes just a slightly less favorable outcome, at least for like what we're looking for in the acute hospital setting. Because our goal is to stabilize people to the point that they're no longer an emergency, do that as fast as possible, and then steward them to outpatient services where the goals can be very different. The goals for outpatient services are more about keeping stability while minimizing the side effects. The amount of side effect from Risperdal and Zyprexa is much more than some of the newer agents like well, in my training, it was like Latuda and Geodon, but nowadays they have even more refined, lower side effect medications like Rexulti, Vraylar, Caplyta, Fanapt. There's just a wide array of newer meds on the market that all do have more favorable side effect profiles. Just they're not nearly as fast, or generally effective in the population, so they don't make sense to really break into the acute hospital setting yet. So with Zyprexa, it's the most effective, and that was shown in the CATIE trial. So, and the CATIE trial for antipsychotics and the STAR*D trial for antidepressants, they're both two keynote studies from the early 2000s that is pretty much required knowledge to be up to date as a prescriber in this arena. So what the Katy trial showed was that Zyprexa was the least likely to for patients to drop out of this study. So you might assume that a real-world study of schizophrenic patients, it's going to be very difficult to actually keep people in a study, let alone really get good results on whether or not they're being treated by other measures, especially when you're trying to follow thousands and thousands of them for years at a time. So what the trial started out with a lot of sort of lofty goals that they really weren't able to meet because of extreme dropout. But the main way that they were able to salvage that and to differentiate between different antipsychotics was the rate of dropout. So Zyprexa suffered the least dropout. Risperidol had pronounced more dropout. And so in a way, Zyprexa was king. This Clozaril also showed to have even less dropout than Zyprexa, and in most measures was shown to be more effective, and that's also part of why we consider Clozaril as sort of like the gold standard, though it's hard to get people. Now, since I'm bringing up some of these other names here, we might just put in the dibenzapine class. Clozaril is related to Zyprexa. So Clozaril is clozapine, Zyprexa is olanzapine, dibenzapines, they're all penes. The other one being Seroquel or quetiapine. And then there's one you guys probably haven't used much or haven't heard of called asenapine or Safras. I have a couple of patients on it. It comes in a sublingual like film. So especially if you need to skip the GI for some reason, that can be somewhat helpful. I haven't used it enough to really see the differences between it and say a Zyprexa. But it is just interesting to know about. And so if you ever have a reason to reach for something sublingual, specifically, it is there. Now, some people might say, oh, but there's sublingual Zyprexa, Zyprexa Zydis. Oral dissolving tablets, which includes the Zydis and the Risperdal M-Tab, as well as other medications that have ODT at the end, oral dissolving tablet. They actually still get processed through the GI. They just don't require active swallowing. So it's sort of like a kid's chewables. You're not actually. It's not like the absorption is not designed to be sublingual in those cases, and there's going to be very little actual absorption in the nasopharynx and mouth. It's still going to be all through the GI, so you're not skipping GI with those meds. Though because they're so sort of pulverized easily, there is a slightly faster onset, but it not that much faster. Okay, so other benzoxazoles is like Latuda and Geodon, Caplyta. I'm sorry, I sort of love the trade names. I know a lot of people, go towards the generics, but I don't know. There's something beautiful about the language of the trade names. They all sound so nice, and so I use trade names a lot. So I apologize if that confuses you. Another one would be Fanapt. Let's see. There's other ones that Invega. So it's important that everybody understand that Invega paliperidone is a metabolite of Risperdal, and for most extents and purposes, you can consider them sort of equal. Their dosing is different, but you can consider them to basically be a very similar chemical. Now, in reality, when you take risperidone or Risperdal, half of the effect on the brain is coming from active Risperdal, and half of it is coming from its most active metabolite, paliperidone, which before Invega was branded, they just called it 9-hydroxyrisperidone. So it's a slightly metabolized version of the risperidone molecule. And so that's why usually before you start an Invega injectable, you usually trial with Risperdal. Now, it wouldn't be improper to trial with Invega pills. They do make those. It's just, I think the reason that that's not routinely the way to do it is because I think that there's at least a perception that the Invega pills are going to be more expensive or harder to get, which may be true. But basically, when you take Risperdal, you are going to have slightly more EPS chance than paliperidone, because the risperidone molecule versus the 9-hydroxyrisperidone molecule have slight differences in that arena. But for the most part, you basically have to dose up with the paliperidone, which you see in the pills. I think it comes in 6s and 12s, whereas risperidone comes in 1, 2, 3, and 4. I think it's also a 1.25 too. So the dose ends up having to be higher for relatively equivalent effect. Quinolones, the only one that gets used readily in the hospital is Abilify, but there are a couple others that are brand name and worth knowing about, because your patients will be on them randomly. And so like Rexulti is Brexpiprazole, and Vraylar is cariprazine, something interesting about Vraylar or cariprazine is that the main actual action is from a metabolite, so the cariprazine itself isn't what's doing most of the work. And also the cariprazine has a much different half-life than its metabolite. So it can. I've found that it's much more likely to have a withdrawal issue than the other quinolones. So let's talk about some special things about quinolones, because I really love quinolones. So for the most part, they have long half-lives, which is convenient in that, like, when you want to stop them, you can just stop them. You don't have to be titrating down. Even if you're at a high dose, it's usually, if you're planning on stopping them, you can just stop them. And also, what's different is, so when we're talking about effect on the D2, so D2 effect, dibenzapines are going to be antagonists. And dibenzapine or benzoxazoles are going to be antagonists. But quinolones are going to be partial agonists. And partial agonism is a sort of complicated thing to understand, and it's something that we could talk about more thoroughly all on its own. But basically, partial agonists have properties such that when you dose them at low doses, they can actually act like an agonist. And then at high doses, they act like an antagonist, but never as a super strong antagonist. Because what a partial agonist does is it partially agonizes. So you get some, like if you want to use a light switch analogy, where like antagonist is you turn the lights off, agonist you turn the lights on. Partial agonist is like a dimmer switch. You're somewhere in the middle. And so if you were in an environment that was basically turned off, you know, a dopamine poor environment, so to speak, and you put it just a little bit of Abilify in there, it would brighten the room, right? It would, going from turned off to, you know, somewhere in the middle, brightens the room. So you're actually getting a pro-dopamine effect in regions of the brain that are low in the dopamine. But if you are high in dopamine, you have a bright room, it's the lights turned on, then going to the middle of a dimmer switch does darken the room, has an antagonistic effect. And so, I mean, this seems like it would be extraordinarily helpful if you think about the dopamine pathways, because, you know, we have in schizophrenia, we have the mesocortical pathway, which causes the negative symptoms of schizophrenia, where dopamine is low. And the problem with using these pure antagonists is you while it does a good job with positive symptoms, it usually makes negative symptoms worse. And that's highly unfortunate. Theoretically, not quite as bad as typicals, because typicals were just very strong D2 antagonists, but you still run into this issue. You know, at least in theory, a partial agonist could, you know, act one way in one part, in one pathway, and another way in another pathway, both to serve the purposes that we want. And Abilify did deliver on that somewhat, I think. Also tended to be slightly less metabolic than dibenzapines and benzoxazoles. But still had metabolic effects. I noticed also in speaking of Abilify itself, in elderly people, it causes about as much EPS as Risperdal, which is strange because in younger people, it's very rare to cause EPS, at least in my experience. You know, just take that for what it's worth. Well, I mean, I don't want to make this video too long, being that it's the first video and I'm just getting used to a lot of stuff here. You know, I really appreciate everybody's hard work, you know, go team.